Markus.
Thank you very much for the excellent talks. I would like to address the molecular biology and particularly the question for homologous recombinant deficiency. You might have seen the publication by Jelena in Cancer Discovery in January, and here she describes very nicely that patients with MSI do respond to immunotherapy, but patients with HRD do not respond, very likely to respond to cisplatin or oxaliplatin, which is in contrast to ovarian cancer or to breast cancer, for example. The BRCA cancers are more likely to respond to platinum. Do you have a reason for that?
No, really not. It's strange for me because we expected that they have some response to cisplatin as observed in different tumor type. And probably this is something that could be said, that if you have a patient that responds very well to oxaliplatin or cisplatin, check for BRCA1, BRCA2 deficiency. That could be because sometimes we find this type of alteration somatic or let's say somatic or germline. But I have no explanation for that. What they showed in cell line, so it's cell line, so we have to take that with caution, that the combination of DNA damaging agent like inhibitor of topoisomerase, which is an enzyme that is implicated in DNA replication. If you inhibit this enzyme, probably you can potentially use the effect of PARP inhibitor in this type. So,
I mean, as you have shown the data from the publication from 2016, the question, of course, is: can we already subgroup our patients according to TCGA with regards to clinical implications? I mean, you showed the data for the.
I think we need to have to start some trials that take into account the different. In fact, we need to characterize deeply the tumors that are included in the different trials that are set up, because otherwise we never answer to this question. We need to have, in other tumor type, a large cohort of patients completely characterized and evenly treated according to, let's say, educated guess that we can done based on the characterization of the tumor, and we need to put the biology up front instead to put in the, let's say, ancillary or secondary objective.
And in that regard, Christoph Röcken made up the point again that P53 is an important differentiator between the chromosomal stable and unstable ones. But I mean, we have been looking into P53 now for more than 20 years, but we never could detect any prognostic and predictive marker for P53 in the clinic under different chemotherapies. Can you comment on that?
All I said that chromosome, my problem is how to define chromosomal instability from a pathologist point of view. That's why I mentioned we looked into chromosomal instability. Looked, is there a common denominator? Is it how you get to that category saying this is a chromosomal unstable tumor? What is the assay? And there's no clear-cut assay yet that we can say this is a chromosomal unstable tumor. From a pathological point of view, P53 is, and we noticed that you need to have P53 mutation in order to get chromosomal instability, because otherwise you will be unable to separate the chromosomes. You will have a cell cycle block if you have disaggregation of chromosomes. The cells stop dividing, so you need inactivation of P53. The problem is if you do P53 sequencing, this is such a huge gene, and if you're formalin fixed material, this is a real task. So it's rather you have fresh and frozen material and then go for P53, but do it on a diagnostic purpose, I think is not the goal. So I'm waiting for assays which we can apply to characterize chromosomal instability, albeit I think it's a mixed buckle of tumors. So we have something.
Ariel Sandor from Montreal. Is there any information on the clinical behavior, the natural history of the different molecular subtypes that are being identified?
You have some...
I didn't get the question.
The prognostic information based on the molecular subtypes of gastric cancer.
Yeah, the prognosis or the clinical behavior. You know, for example, propension for distant metastasis, local recurrence, involvement of regional lymph nodes, etc.
Well, yeah. Well, it's not that clear-cut. If you take, for instance, CMET has a very poor prognostic influence. HER2 is very controversial. Some believe HER2 amplification is associated with prognosis. There are other data where there is no prognostic. So within this SYN group, you already have two different types of tyrosine kinase receptors with different effects. EBV, mixed message. Microsatellite instability, that's clear. Microsatellite unstable gastric cancer clearly have a better prognosis. That's all we know so far.
And from the TCGA, analysis, it's very difficult to have very robust, let's say, clinical data, which can, because it's a mix of different series coming from different countries, treated with different type of treatment. So to have a clear picture from from these, let's say, large, deep analysis and to correlate with survival, TCGA is not in fact the good database to do that. Because tumor come from different country, different type of treatment, so it's difficult.
I have a question to Christoph Röcken. Is there still a place for normal pathology? I mean, other than saying that it's adenocarcinoma and then all the rest you have to do with molecular classification?
The question is
correlation
do we
between
need
molecular
pathologists?
data
That's the question.
do we need some pathologists to classify behind adenocarcinoma?
Well, so. Now there is clear, there's still, yes, there is some, you still find a good reason to do histology. Because what I'm stressing, which I haven't stressed today, the biggest issue in gastric cancer is heterogeneity. And you know they've done research on that. And I think this is one of the biggest problems for the future. And that you really need to do histological assessment to realize, are you dealing with heterogeneity or not? And if you're dealing with heterogeneity, then you may really go into thorough sampling to identify what is my target, is it appropriately expressed, how much is it there? And we also have evidence for heterogeneity with regard to, we found tumors which were microsatellite unstable and stable. So I think it still needs a good histological assessment to identify heterogeneity. And there are also some types of tumors which bear variants. I always fear these small microtubular adenocarcinoma of the stomach. They look so nice, so well differentiated, but behave so badly. So there's still a point for histology.
Bill Allen from London. I like pathologists as a surgeon, so I think you've got a job to keep because of helping us.
Thank you.
Thank you.
Questions for
Take
Paul.
my pension.
Questions for Paul Schneider. Tony LaRoute's work showing 25% of cervical nodes are positive. In practical terms, do you think it's relevant? Because if you take that on, it begs the question of whether we should be approaching the cervical nodes as part of the lymphadenectomy. We don't, because we're worried about the recurrent laryngeal nerve and things like that. And also in practical terms, the natural history, we don't see many patients relapse with cervical nodal recurrence.
Thank you for the question. Not in principle. I think the same is true, for the para-aortic nodes. But we have now, if we have metabolic labeling tumors, that means PET-positive tumors, We are very good with the positive predictive value in lymph node metastasis in high paratracheal region, cervical region, and para-aortic region. And if we have a positive node, and if we have a tumor that is responding, then we should think about removing that, but not in principle, not for every patient.
So are you repeating your PET-CT after FLOT if you've got a positive cervical node?
Yes. Yes. Yes.
I'm Toshima from Japan. I have one comment to Professor Schneider. You mentioned about the para-aortic lymph node metastasis from EG junction cancer, especially for GBL type 2 cancer in Japan. The para-aortic lymph node, we usually think the left side supra renal vein area, we call it a number 16 A2 lateral.
Yes.
It's a kind of a regional lymph node.
Yes.
It's quite different from the other area. So you demonstrate the PET scan photo is a metastasis in the intra-aortocaval area.
Yeah.
It's quite different from the number 16 A2 lateral.
That's right. But many times you have, as in this case, you know, we had several lymph nodes. We had the one on the left renal vein, which is a 16A2 node. But we had one in we had in 16A1, and even in this patient in 16B compartment. So you have to individually look. But I agree with you that this one, the 16A2 on the left renal vein, is I consider regional.
Yeah, it's kind of regional lymph node.
Yes,
so
yes.
it's worth to lymph node dissection. It's in many papers. The efficacy rate is very high. So
yes.
that's a just comment.
No, I agree with you completely.
Ludwig Blaspham, Radiation Oncology St. Gallen. I would like to come back to the point of prognosis and subtyping the cancer. Are there sufficient information available to say which kind of cancer will be more or less in the local progress, or which kinds of cancer will have a regional progress, let's say lymph node metastases, or which kind of cancer will have distant metastases more than the others?
None has stood the test of time yet. That's the clear message. I mean, TNM is the best prognostic marker. There's abundant literature on TNM staging, and as well as intestine diffuse type and microsatellite instability, and that's it. So we have an overwhelming number of publications testing prognostic biomarkers. If you go into that topic and ask what is the prognostic biomarker, any study explores prognosis, but none has stood the test of time or being translated into clinics. We also assess Ki-67. Is Ki-67 informative? Oh, it's very controversial literature. I wouldn't rely on that. So I think it's very, very complicated to have the one and only prognostic biomarker beyond TNM classification and beyond Lorraine.
Okay, thanks.
Oh, you haven't forgotten your question, Florian, huh?
No,
good.
More questions now. No one mentioned Barrett's epithelium in esophageal adenocarcinoma. Is there any role for the existence of Barrett epithelium when you analyze esophageal adenocarcinoma? Are you aware of any data if carcinomas with or without Barrett's epithelium have a different prognosis, different outcomes?
No, I don't.
There is some molecular biology, but I'm thinking if there is some link with the tumors, but I don't think so. There is a recent publication on that that characterized Barrett esophagus and the tumors, the corresponding tumors, let's say. But there is, I don't think they correlate with prognostic. I have to check, but there is at least one publication that compare what is fine in the Barrett esophagus and in the tumor.
There is also a problem with, because the majority of the tumors are locally advanced tumors, and then the Barrett is overgrown.
Overgrown.
Yes.
Yeah,
and when you can clearly see it, or you have a long segment, then Barrett's esophagus. That's if there you can see it. But if you see it, you have an early type cancer. And if you compare prognosis, it might be not different because are early type cancers. So it's really difficult. This question is not answered yet.
And I have another silly question like that. No one mentioned Helicobacter pylori. Is it still worth looking at it? Is it associated with tumor biology? Does it make a difference in terms of prognosis?
Well, yeah, we always look for H. pylori in every specimen. I'm surprised that I've worked at different hospitals in Germany, and I noticed there's a regional difference in the prevalence of H. pylori, interestingly. In North Germany, where I'm working now, I rarely see H. pylori. So I think the shift we now see, the epidemiologic data have shown, there is a shift towards the proximal carcinomas, esophageal, and I think this is not H. pylori associated. So there must be age-dependent methylation patterns which influence in etiology. So you still have to look for H. pylori, particularly in stomach cancer, but we do have an increasing number of cases where H. pylori may not be the initial agent anymore, at least in our region. We're not talking about Chile or some other hotspots. But,
And may I ask a last question on MSI? Again, maybe first to Christoph, but maybe to all the others as well. You said that you propose to measure MSI primarily in all cancers. Does it really make sense in esophageal adenocarcinoma where the prevalence is so low?
If it's clear, that's the problem. It's not always that clear if it is really an esophageal carcinoma. I've received lastly two cancers supposed to be esophageal cancers. Both were clear-cut stomach adenocarcinomas. There was no, the junction was present. I didn't find any Barrett's lesion. So I wonder whether this is a ZEVA3 extending into the esophagus. And I would go for MSI. This is the only prognostic information I can provide from a histological point of view. And all I have to do is two immunostainings, MLH1 and MSH2. If they are negative, one of them, and then I can go for macrosatellite instability and give you the example, but it's only two immunostainings.
What can I add is that on the series, so the compilation of the 3 series published in Broad and by the TCGA, in fact, the 3 cases came from the same series, which is that have been published in 2017, so the last paper of Nature. So these series show that there is 3 MSI. So these series have been well characterized in terms of positions. So probably the rate of MSI in esophageal adenocarcinoma is low. But since the consequence for the patient is important, I think we cannot say that we have not to screen for MSI in these tumors. I don't know what you think, but since you have one treatment that is supposed to be efficient.
Thank you.
We have one more question.
Hi, Rebecca Fitzgerald from Cambridge, UK. If you don't mind, I just want to comment on that question about prognosis and association with Barrett's, because we've just looked at our large series and found that there is a difference. And that's even if you take away this question about whether you're just looking at earlier tumors. So what we did is we went back and looked not just endoscopically, but for pathological evidence of intestinal metaplasia, and then did the analysis even if you take away the early stage tumors, and you still see a survival difference, which actually surprised me. So the Barrett's-associated adenocarcinomas or the IM-associated adenocarcinomas do better than those where we couldn't find any intestinal metaplasia. And interestingly, the Mayo Clinic have found exactly the same in their series. What I'm frustrated is that I can't tell you the molecular explanation. A lot of these cases in our series have been sequenced, so that's something we hope we'll get to the bottom of, but we do see a small but significant difference.
Okay, I think we're drawing to a close here.